Thanks for inviting me today. It's a real honor and privilege. So we're going to step away and just briefly touch upon renal mass biopsy. I have no relevant disclosures. Today's talk, we're just briefly going to discuss the guidelines, review current status, try to ask the question who to biopsy, and then I'll just briefly say how I do it. So the NCCN guidelines, with regards to biopsying a small renal mass or a suspicious mass, they really only recommend its use if there is going to be guidance to either surveillance or ablative therapy. Now with systemic disease, stage 4 disease, they do recommend tissue sampling, and this is largely in part because the tissue diagnosis helps guide therapy, particularly in differentiating clear cell from non-clear cell. The AUA, with regards to its guidelines for renal mass biopsy and localized disease, they're fairly specific, and they recommend biopsy in patients in which we don't think it's from a urologic origin. So in hematologic disease, metastatic disease, or if there's concern that there's inflammation or an inflammatory process. Who not to biopsy, they don't recommend doing biopsy in younger patients, particularly if they're unwilling to accept the uncertainties associated with biopsy, and also in older or sicker patients in which knowing the tissue diagnosis really won't change the management. With regards to the safety profile and accuracy of it, they highlight the low complication rates and the low risk for major complications requiring transfusion less than 1%. And they also highlight that there's no reported cases of tumor seeding with contemporary literature, and highlight that on average there's a non-diagnostic rate of about 8%. With regards to how to do it, either CT or ultrasound guidance, recommending at least 2 to 3 cores with a 16 or 18 gauge needle with a coaxial technique, and they recommend against FNA. The EAU are a little bit different. They recommend biopsy in patients who are being considered for active surveillance, in all patients undergoing ablation, and also in patients with metastatic disease in which we need to know that tissue diagnosis to help guide systemic therapy. They don't recommend biopsy in any patients who are considered surgical candidates because they don't think that it will impact management at all. And then in a patient who's sick with comorbidities that would prevent treatment, they don't recommend biopsy in those either. Again, they highlight the high accuracy and specificity of a cancer diagnosis, but and then quote the similar rate of non-diagnostic rate of about 8%, and then a low complication rate with significant bleeding less than 1%. They're a little more specific with the techniques. Again, CT or ultrasound guidance, always at least 18 gauge, a coaxial approach. Cores should be done with the exception of cystic lesions when you should consider doing FNA. And in larger tumors, you need more samples to look for sarcomatoid features, as well as if there's areas of necrosis, we should try to avoid those and get the where the tumor is. And again, report that the tumor seeding is anecdotal. So that patient thought that if I get a renal mass biopsy, is it going to spread, is not really true. With regards to ASCO, they really just say that small renal mass biopsy should be done if it's going to change management. They do, however, highlight concern over the low negative predictive value. So how do you deal with that oncocytic neoplasm? And they highlight the difficulty pathologists have with just a biopsy in differentiating an oncocytoma from a chromophobe. And they also report similar non-diagnostic rate of about 8%, but report that and highlight the fact that in some series, the non-diagnostic rate can be up to 20%. So survey says if a biopsy is going to guide therapy, then it should be done. When it is done, it should always be done with a core biopsy. FNA should be done not usually, only in cystic lesions. The non-diagnostic rates are encouraging, on average about 8%, but they can be as high as 20%. I mean, I think when you look at your institution, you kind of have to look at your interventional radiologists and see how good they are. There's some good ones and there's some bad ones, so you want to be comfortable with that interventional radiologist. Or if they are doing the biopsy, make sure you're sending it to the right one so she's doing it so it's consistently excellent. Major complications are low, tumor seeding all anecdotal, and it should always be done prior to ablation. So where are we with regards to the use of renal mass biopsy? So this was literature from John Leppert, and he looked at the SEER database from 1992 to 2007, and they found that in this period of time, the use of renal mass biopsy was about 20%. And on the bottom there, that little, I can't point, but basically for ablation, about 2/3 of patients undergoing ablation at this time were getting renal mass biopsy. So that was encouraging. This was another study looking at the use of renal mass biopsy from 2003 to 2011, and the use of this averaged about 12%. And again, you see a slow increase in the utilization of renal mass biopsy. We recently looked at the SEER database from 2004 to 2016, and we found on average that rate is much lower. So for patients undergoing surgery, only about 5% of patients had a small renal mass biopsy, and more concerning, patients undergoing ablation, only about 50% of patients had a renal mass biopsy. So although initially we thought renal mass biopsy may have been increasing, it appears that it may actually be decreasing. And why is it not being done? This was a study from Dr. Klayman's group where they polled 1,000 urologists and asked, why wouldn't you do a biopsy? And the large majority of them said, because it doesn't change management. So when will renal mass biopsy change management? And I propose perhaps small renal masses. This was a study that looked at 18,000 patients who underwent partial nephrectomy for a small renal mass. And as you can see, almost 1/3 of them are done for benign tumors. So it makes you question, do we need to be bringing 1/3 of patients to the operating room for a small renal mass if it's going to be benign? When it is justified, absolutely in ablation. We know that ablation, the pathology helps dictate outcomes. So if it's a non-clear cell or a papillary, you're much more likely to have a good treatment success, or if it's benign, you're more likely to have treatment success with ablation. In advanced disease, again, necessary to help guide systemic therapy. And then the question is it useful or can it be useful for small renal masses? With regards to how I do it, I use CT or ultrasound guidance. I always use an 18-gauge coaxial technique. I do it with local anesthesia, with or without conscious sedation, depending on the patient's level of anxiety regarding the procedure. I get at least 4 cores on average, probably more like 8. I will biopsy cystic lesions, but if I do that, I'll park the needle within the normal renal parenchyma outside of the cyst, so I'm sampling the cyst edge. And once that's done, then I advance the needle and get the fluid for cytology there. And in all patients who get ablation, we always biopsy them, preferably before, particularly if the lesion is less than 2 centimeters, but if not before, at least at the same time. Thank you very much.